Good evening. Tonight I'm going to be presenting to you a topic that I find to be one of my favorite topics in dentistry, and one of the things that I think a lot of people struggle with when they start doing digital dentistry. It's how can I predictably make anterior restorations that mimic the natural dentition. So I'm going to be presenting on a topic called shaping up your anterior crowns, making the ordinary extraordinary by utilizing tools in the software and some simple tips and tricks that you can use in your laboratory as well. Overall, this is my financial disclosure statement. These are not the views of the United States government or the Department of Defense, and I do not have any financial interests in the companies whose products and materials I discuss in this presentation. All the images here of patients, of crown preparations are all mine or have been taken by me. Any of the presentations, the images haven't been altered. If I did alter them to prove a point, I will definitely make sure I point that out to you, but all of my images of anterior teeth remain unaltered and in their original state other than being cropped. So going over our outline, what are we going to be discussing today? So one thing that I like to do first is talk about considerations in anterior success, looking at things through a lens of biology, through engineering, and through chemistry. As dentists, we have to be all three things. Once we go through the considerations for anterior success, we have to be able to plan our cases accordingly by recognizing the problem. Then we have to communicate this and record our findings along with our patient, to our laboratory, and even to ourselves. And finally comes the difficult part, right? We have to execute. We have to replicate the anatomy, and we have to replicate the records that we took in order to have a restoration that mimics the anterior dentition. So I find it through case presentations you're going to see of cases that I've done in my clinic. Some of these cases I try to get away with the fewest number of all ceramic restorations possible because I find it to be a really fun challenge to try to make these restorations disappear into the dentition. So in case you all weren't aware, I come from a background in the United States Army. I also have a background in dental education, teaching young dental residents. So anyone who's had me as a mentor probably has felt like this at one point or another during their training. And why are these fine gentlemen doing an on-the-spot correction with this soldier? Well, it could have been because he wasn't standing in formation correctly. He maybe didn't say, "Sir, yes, sir." Typically in my residency program, I get frustrated when residents forget the first and the most important thing when we talk about anterior all-ceramic restorations. We have to address the patient's chief complaint. There's nothing more than I can drive home. What I think is beautiful isn't what the patient is always going to find as being beautiful. Even though it's cliche to say it, beauty truly is in the eye of the beholder. This was a young man that came into our office with 2 broken anterior teeth. We did the non-surgical root canal therapy, and that same morning discussed with the patient, well, let's go ahead and put some all ceramic crowns on these teeth. And luckily we asked him, do you have a picture of what you looked like prior? And this is the picture he gave us. Now, obviously this is before joining the military, so hair isn't exactly in regulation. But when I asked him, do you really want us to restore that chipped incisal edge and that cant to your midline? He goes, "Doc, I want my teeth to look exactly like they did before." So here's a picture immediately after we got done with the non-surgical root canal therapy, and we finished the crown preparations. And you can see here that here's our final restorations. Now, not something that I would typically deem beautiful if this was my final end result when I was going for coincident midlines and no cant to my midline and uniform incisal edges, but for this patient, this truly was a beautiful set of restorations. So even though the first thing that draws my attention on this screen is the diastema or space on the lower left-hand side, the patient's chief complaint is, "I don't like my front tooth." Okay, So let's go ahead and start from here. So where do we begin? Well, let's understand our biology. So with biological substrates, there's a key role in communicating our restorative needs to our patients. So as the picture you see on the right-hand side over here, you can see that that tooth is dark. Well, the patient that just came in to see us, his tooth was dark. Well, we have to understand what biological substrate we're dealing with. Do we have a vital tooth with a high-value stump shade compared to a non-vital tooth? So in this case right here, look at how dark this patient's restoration is. You can see just between tooth number 7 and tooth number 8, the difference in our stump shades. So that's going to affect how we can overall get an aesthetic looking restoration. With situations like this, sometimes you're stuck. If you want to do a tooth in a single visit, there's studies like this one that's quoted below saying that 2.5 millimeters of Emax low translucency was needed to have a low perceivability in our delta E or in our color change for this tooth. Well, 2.5 millimeters of thickness is really against almost every concept of conservative anterior dentistry. But you have to understand we do have some tricks up our sleeves. We can do things like thin coatings of resin opaquer, not just opaque resin cements. Opaque resin cements don't do a great consistent job of blocking out a dark stump shade. And you can see here that we maybe even almost overshot the value of this restoration a little bit. It's okay. I like to aim high on my restorations when it comes to value because it'll all correct itself in the end. So biological tooth development will also dictate our natural tooth contours. You have to understand that form follows function and form follows parafunction. So as we go through this presentation, you'll see the case that we kind of lean on throughout the entirety of the presentation has wear on his lateral incisor. Well, we don't necessarily want to restore that because that's actually part of the patient's function and probably a little bit of their parafunction. You can see here that biologic development dictates the natural tooth contour. Obviously, doesn't just hold true for our patients that are human beings. You can see in veterinary dentistry with this CAD/CAM we did here, the biological development and what that tooth's purpose is dictates its final form. Now you're probably asking yourself, can a CAD/CAM restoration hold up in a dog? Well, overall, here's our 1-year follow-up appointment. We decided to put on a bite suit, and myself and the endodontist decided to put ourselves in front of the handiwork of this military working dog. And you can see our arms on the right-hand side are proof as to the strength of our dentin bonding agents and the strength of our all-ceramic restorations. When we talk about the biological substrate, we have to understand that biology and engineering are definitely they go hand in hand, and they play a role in each of our restorative material treatment decisions. So restorative materials should be chosen on a basis of compatibility with the properties of our underlying tissues. So if we have something like enamel, we might choose a different material than if our substrate is purely dentin. So overall, our tooth substrate will also affect our restorative design. When we have teeth like you see up here in this young man, where he presented with multiple diastemas, we are able to get away with a fairly minimal prep and 100% enamel on the entire preparatory surface. So enamel veneers compared to a dentin bonded veneer, they're going to look totally different, and that's going to go into our engineering perspectives. So in the anterior dentition, we're trying to mimic the structural engineering of what our nature provides. This is the principle we refer to as biomimetic dentistry, which is what we try to do and what we try to mimic when we're doing all ceramic restorations. A few years back, one of my dental residents did a really nice presentation on biomimetic theory when we choose our all ceramic restorations and develop this really nice chart. When we look at it, we can see things like enamel and Emax stick out to us as having the highest gigapascals of elastic modulus, meaning that they're our stiffest materials that we have. We look at things like Deep Dentin and Ceresmart. They tend to be some of our more flexible or low elastic modulus materials. So in dentistry, in my opinion, there's not one restorative material that does it all. We have to have that continuum of materials to understand how we restore teeth based on the depth of our preparations. So when we look at engineering and chemistry, they play a vital role together because we used to engineer resistance and retention form by our prep design, our wall height, grooves, and pins. Well, now adhesive dentistry introduces micromechanical and chemical bonding, which changes our overall restorative design. So you can see on the top, this patient ended up being an all ceramic restoration where we had to have a deeper marginal preparation because of our gold post in the tooth versus you see this enamel bonded veneer on the lower right hand side. So now that we've kind of talked about some of the considerations for anterior success, we're going to talk about simplifying our criteria for aesthetics in the anterior. So it's the 3 R's and the 3 C's. First, we need to record the problem. Then we need to recognize what we've just recorded. And then we have to be able to have the hand skills to replicate it. Or we have to recognize our own limitations to send this off to a lab that can replicate it for us. When we're looking at replication, we look at a couple things. I start with contour, overall anatomical shape as being the most important, followed by surface texture, and finally by the color. And if you have any question as to what I deem the most important type or the most important aspect of color, it is value. Value is key to the success of our anterior aesthetic restorations. So this is an absolutely great article for anybody that's looking to do monolithic restorations, what's called the Triple R protocol. So with this Triple R protocol, what we need to do first is record. What do I use to record? Well, I use photographs. You know, you hear the adage that a photo or a picture is worth 1,000 words, and it truly is. And it's something that I lean back on the entire time I'm doing these restorations. Even if you don't take a myriad of different photographs with different mirrors, get yourself a really nice basic DSLR setup and take some maxillary anterior photos. The setup that I have, I tend to be a little bit of cheapskate. So I have a Canon Rebel T7, which I think on Amazon is going somewhere for around $280. I have a Tokina 100mm macro lens, which is around $429. And then a Yongnuo YN14EX flash, which is around $115 to $120. So overall, it's not a very expensive setup. But what does this let me do? Well, it lets me make some considerations when the patient maybe isn't in the chair. One is the incisal edge length of tooth number 8. We can draw a simple outline. You know, I don't have something fancy like Keynote. I don't have a Mac. I just have a really basic PC. So in PowerPoint, I can just draw a simple outline and then flip and mirror that. And we can see that we already have a couple issues. The tooth seems to be a little bit narrow and a little bit long. Then when we take a side profile image, you can see that we not only have a long, narrow tooth, but we also have a distal diastema to that central incisor. So this is all going to play into some of the proportionalities of these teeth. So now we have to recognize what's in our photos. So a lot of people like to talk about different softwares you can use to recognize proportions of teeth. Some people use digital smile design. Some people apply these really fancy rulers. I'll tell you an easy way to do it. You just go into your picture format tools. So drag an image into PowerPoint. Once you click on that image in the top right hand side, you'll see the picture format tool. You then go to the crop. You don't actually crop the image, but you outline the tooth with the cropping function. If you go off the incisal edge to the gingival zenith, and then your mesial and distal contact points, you're going to get an approximate width and height ratio. So when you divide these out, you can see that this patient has a 0.79 ratio of their central incisor. Doesn't matter what the unit is because the units cancel themselves out and all we're getting is a ratio. So when we look at this study by Monnier, Gallucci, and Belser, you can see that proper unworn central incisors should have a lip to length ratio of around 78 to 80%. So let's look at the tooth on the other side. So when we take that same function, drag it over to the other tooth, which took me all of about 20 seconds to do in PowerPoint, you can see here that we have a tooth that is a little bit too skinny. The problem is it's a little bit too long and we have a diastema. So once we shorten this tooth, our proportion is now going to be very similar to that tooth that we have on the contralateral side, but now we're going to have this diastema that's going to widen the tooth and violate the length to width proportion. So that photo that we took, or those two photos, just spoke about 10 minutes of patient problems with this tooth. The next thing we have to talk about is recognizing consistency of teeth. So we see the contour issue and we recognize that. So let's go to our second C, our consistency of the tooth. So we want to develop a topographical map of the tooth. I love this picture of my kids because this is exactly how I felt when I unboxed the Prime Scan. This is exactly how I feel when I get my new Mayo stain from Jensen, when I get my new abrasion kit. I want to use it for everything, right? So my kids got a box of pipe cleaners and they wanted to make everything from butterflies to watches to glasses out of it. So we always want to use what is in front of us. But I also think of the imagination of my children and some of those things that we can apply to our everyday practice. So when I recognize the consistency of teeth, I think of the practice of leaf tracing under a piece of paper. So this leaf was traced by my daughter. It's a pretty awesome maple leaf that we found just down the road from our house. And I thought about it, you can do the exact same thing with articulator paper to trace a natural tooth. So you can see here, when I work on a central incisor, we take a little piece of articulating paper, we drag it across, and then we can recognize some of our topographical features of our tooth. So in this instance here, this is a case that we presented back when we were talking about dark stump shades. You can see that tooth 7 and 8 blend in very nicely with the patient's anterior dentition, and so much of it has to do with the consistency of the teeth and the overall tooth contours. So I like to say a simple swipe will save a lot of guesswork. So if you have your smartphone, you can go ahead and pull that out, aim your smartphone under the camera setting at that QR code, and it'll take you to a video that I prepared for this lecture on how you can use articulating paper to identify the surface consistency of your teeth. So if you don't want to go to that link, you can just imagine I'm going to take that articulating paper across my model, and we're going to go ahead and we're going to mark the heights of contours of our teeth. So overall, we're starting to develop our topographical map. So as we start to draw this map out, which you can see is being drawn on the left-hand side of the screen, what we're going to find is that the red is an actively removal area with a coarse grit wheel. We're going to actively remove material from our all-ceramic crown. The blue is an area or a line angle that we want to try to avoid touching with a coarse wheel and maybe polish when we get to our medium and our fine wheels. Again, if you want to watch me walk through this entire process on a 6 through 11 anterior case, you can take your smartphone, point it at that QR code, and it'll take you to a video that I prepared on managing the anterior dentition and how we walk through 6 teeth systematically. To stick with the theme of this lecture and try to stick with a single central incisor, I can show you a basic case example of this tooth right here, where we go ahead and we mark a single anterior tooth with articulating paper, we draw out a topographical map of the teeth, and then ultimately with a single anterior monolithic restoration that's been stained, we're able to replicate anatomy very easily. Finally, let's go to the last recognized feature that we have, recognizing color. So we've gone through our other 2 C's, and let's get onto recognizing color. The reason the picture is black and white is because I want you to start with a value and I want you to aim high when you're choosing your all ceramic restorations. So value is the degree of lightness or darkness of a color. So I used to work at a hardware store when I was in high school, and I never thought that my paint matching skills would come to help me in dentistry. But I always remember when people would bring in a paint to match, and they'd bring it in on a textured swath, and then I was supposed to match that color. Whatever B or black colorant was required by the color matching machine, I would omit until I mixed the paint, I shook it, and I tested a sample. Because we know that as things dry, things can darken. So it's lightness and darkness of the tooth. Hue represents the physical wavelength of the light. So hue is the actual color. Is the tooth orange? Is the tooth brown? Is the tooth a brownish gray? And then chroma is the intensity of that hue. So how brown is brown? How white is white? Those are the things that we think about when we think of chroma. So it would be a variation of the intensity of the color. So when we think of the Vita Classic Shade Guide, it's not organized intuitively, right? We have all the B's grouped, all the A's grouped, all the C's, and all the D's. But if you actually organize it based on value alone, which I think is a very smart way of doing it, you can actually see that the value or the position of these shade tabs changes significantly. And it's an interspersed kind of grouping of B, A, D, C, all mixed together to give us the best lightness to darkness value. Okay, so we've gone through our 3 C's, and now we're onto the replication step. So we have to replicate the biological contours. I'm sorry, but when there are diastemas and there's certain things that are asymmetrical, there's no way for us to replicate that asymmetry using CEREC, no matter how good we are at playing with line angles. So for this case, I kind of went back to an article that I read on the management of a relapsed midline diastema in a single visit. And what that is an article out of the Journal of Clinical Orthodontics where they use different modalities to close a midline diastema very quickly for a patient. Well, what we did for this patient was actually utilize a CEREC pre-op scan for an in-house limited clear aligner. We used a 1mm clear splint material. We did digital models. We added buttons to the models utilizing the add function under the edit model phase of our CEREC chairside software. We then used medium elastics, and we get about 1mm of movement per month. And this patient was instructed to wear this appliance for 18 to 22 hours a day. If you're interested to see how I made this appliance or to see if this is something you could use in your patients, I guarantee you won't find a research article on it. It's one of these things that I've been meaning to get published. But it's something that we kind of developed when we were in residency. And overall, you can see from this case example of the elastic being worn, what the patient looked like about 3.5 weeks later. So overall, we were able to close that diastema, and now we're only dealing with a minor length to width discrepancy that can be addressed by changing the incisal edge length and maybe playing with some line angles. So we're going to talk now about replicating some of the biological anatomy with software tools and functions that we will find. So biogeneric individual uses the data of adjacent teeth and it cross-references them to a database developed of a restorative proposal. So what design concept do I actually use? The design concept that I actually use is something called GMM, or Global Macro Micro. I'm sure some of you have heard some other acronyms in the past for how you would actually design these types of restorations if you're looking at single posterior teeth. I like the global, macro, and micro type of thinking because it can be applied to just about anything. So I actually designed this in the chairside software, but because of my screen capture ability, I only have screen capturing available on my in-lab computer. So biogeneric individual is my go-to in 95% of my same-day situations, but it's only a 75% solution. So as I'm going through, I always go back and double check my parameters. I like my margin thickness to be at about 100 microns to allow for manipulation at my marginal areas. As you can see here, I'm utilizing my global positioning tool to increase or decrease my incisal length, change my overall tooth contour. So I use the move and rotate to line up my incisal edge and scale to increase my width. So overall, you can just see right here that I'm going to recalculate the proposal, and from the top screen to the bottom screen, by playing with those tools, you can see how much better, by going back, making those two simple tweaks, we can actually have a much better looking restoration. The next thing we're going to be discussing is our macro positioning of our objects. So what this does is I like to use the two-directional circular or anatomic shape tool to take my line angles, mesial, distal, and even my lingual, to bring these areas out, allow myself to capture light. So what I like to do is slowly roll the image. You can see myself doing here in the screen. And what I do is I roll this in many different ways that we maybe couldn't capture in the patient's mouth, and I'm adding or subtracting bulk. For this instance here, you can see that the tooth still looks a little bit wider than its neighbor. So what are we going to do? Well, anytime we try to close a diastema, we try to pull that material towards the lingual, and then we can take that distal contour and tuck it in to play a little optical illusion to allow that tooth to appear to be the same proportions. So the mesial line angle should almost always be more defined than the distal line angle, which you'll see as we kind of move through the rest of our presentation. So we're going to talk about this a little bit more using the incisal variation tool on our next screen, but that gets us kind of to our next topic, which is what we call micro positioning. So this can be done with a handpiece. When we talk about this method of replication, it can be done with the incisal variation tool. And one interesting thing that people don't understand in the last step is this variation tool, you can left click and drag it around to get that anatomy where you want, which is something that I'll admit I didn't know for probably the first 3 or 4 years that I had this tool. And I hated it. It was like, it made my teeth look so unnatural. When I realized I could take that incisal variation and drag it around, it made me much happier, and I actually use this tool quite often, especially when I'm doing my diagnostic wax-ups, when we get to our full arch type of cases or even our multiple anterior type of cases. I usually start with about 30%, and I start to move it around until I get the consistency that I desire. Once I start going on to the gingival aspect of this, I want to get into variation 5 and variation 6, which you're going to see me do here in a second. Variation 5 and variation 6 will put those horizontal characterizations that we typically see with horizontal developmental grooves. The last thing that I'm going to do at the very end is use our form tool, which is our add, smooth, remove, and I use this at the very, very end for my last overall step, which you can see that I'm doing right here. A lot of people will think, well, what about the copy and mirror function? Well, it utilizes a copy line to create a mirror image of the contralateral tooth. The issue is most of our patients aren't symmetrical, even if they appear to be symmetrical. So what I tell people is, for a 95% solution, if you want to do very minimal work, do a wax up and do a biocopy. If you do copy and mirror, in this situation here, you can see the initial proposal that we get. And overall, it's not a very good initial proposal. And the study that I have down here below pretty much says the same thing, except not in such a pictographic type of method. It uses finite elemental analysis and computer modeling to show you that biocopy gives you a much better replication of what you're trying to achieve in the anterior dentition. So I joke that I like the challenge of same-day anterior, but maybe I'm a little strange, right? So here's one of my typical hands-on courses that I run, and you can see we've got a live patient. I like the idea of having a lot of people gathered around or huddled around like an old school medical professor, because I feel like this is how we can truly pass knowledge. So I'm going to try to bring that in the rest of this presentation with you in the room and you watching online to try to pull you into my operatory and show you what I would do up close. So the one thing that I want to start with is the wax up and biocopy type of example. So to walk you through how you would do a biocopy, again, pull out your phone and you can see my method for doing a biocopy utilizing the in-lab software. But here, this patient's chief complaint is, I don't like my 2 central incisors. I want these restorations replaced before I get married. So we went ahead and did a diagnostic scan and prime scan, did a very quick wax up in CEREC InLab, brought the models together in Mesh Mixer, printed a 3D model, and then did a putty matrix in the patient's mouth. So you can see here that this is the day of preparation. Here is our 100 micron model that we used to go ahead and put bisacryl over the patient's teeth. Well, then I scan this in as my biocopy upper once the patient accepts the overall appearance of these teeth. Then I don't just pop them off, I prep through them, because this is going to give me my best type of overall preparation to support the material thickness that's indicated based off of my wax up. And this is the final preparations that we end up with. So overall, it does a very good job not only understanding our biology. We have enamel bonded veneers, so it preserves that enamel bond. It helps us with our engineering because we've engineered proper material thickness for Emax medium translucency. And now let's go ahead and let's get into the contour and consistency post milling to make our ordinary restorations out of the mill look extraordinary, like these 4 Emax restorations. So when we talk about an anterior finishing sequence, here is the basic sequence that I like to use. So as you can see, the kit that I have here is a Brassler kit. It's a mixture of dialite and featherlight. There are many different kits. Meisinger has a kit. Many different Ceraglaze is another kit that I used quite often at other assignments that I had. But overall, I'm going to walk you through this basic sequence. As with anything, I want to make sure that you're safe. So make sure that when we are actually adjusting porcelain, whether it is something like lithium disilicate or zirconia, you have proper ventilation, and make sure that you read your MSDS or safety data sheets to understand what type of respiratory controls that you need. So I like to wear N95 masks whenever I'm adjusting my zirconia and when I'm adjusting my lithium disilicate. So pre-staining finishing. So whenever this crown comes out of the block, the first thing I like to do is take a pencil, whether it's blue or a standard graphite pencil, and draw around my sprue. Mechanical pencils work great because they're always a nice sharp edge. We're then going to use a diamond to remove the sprue. So this is a Kerr diamond, or sorry, I apologize. This is a Brassler diamond. And it is I believe this one is a non-sintered diamond. And this right here, I use this in a sweeping motion to remove that sprue until only one side of that pencil outline is visible. Then what I'm going to do is once I've removed that sprue, probably about 90%, we're going to go back and we're going to turn all of these little marks into our topographical markings into something with our blue knife wheel. So our blue knife, we're going to use that in an incisal to apical direction, and we're going to try to stay off of the blue areas that we've marked on the tooth when we utilized our method of articulating paper to mark our heights of contour. We're then going to take that red knife and we're going to do the same thing. Now, when I get to the red knife, what I'm going to do is I'm actually going to go over those blue areas and start to smooth anything that looked like it was a deep V depression that I caused in those red areas where I was trying to remove that blue coarse wheel. But I'm going to follow the exact same pattern, going in a coronal to apical direction and then sweeping horizontally across to accentuate my horizontal developmental grooves. As I go through a little bit further, what I'm going to then use is my featherlight to remove my blue lines and smooth line angles to reflect light as a crisp, flowing, curved line. We never want to have extremely sharp right angle edges. But in this instance, what you can see here is the patient does have a couple little incisal edge chips. Well, how do I create those? Well, you can use a diamond disc at a very, very slow RPM. You know, you're talking 2,000, 3,000 RPMs maximum. Or you can use a pointed cone like we have here. This is a Brasseler sintered diamond. But overall, this can start to create some of that really fine anatomy or some of those scratches that you might start to see appear on the adjacent teeth. So you can see here our before and our after, what I would deem the ordinary on the left and the extraordinary on the right. It's really not all that difficult. It just requires some practice and a little bit of patience. I'm telling you, if you use that method of articulating paper, dragging it across the teeth, just bring yourself back to being a kid, right? We did this all the time to trace outlines of leaves. How is it any different than tracing the outline of a tooth? So overall, these are really basic concepts that people really make to seem like they're these unattainable results or unattainable goals. It's really just using your imagination and using tools you've had since you were a kid. So now we've talked about replicating our biological contour. We've talked about replicating our microanatomy or our consistency of the tooth. Now we have to replicate the color, our final C, by replicating the shade and selecting the proper block. So again, we have to go back to some of the principles that we talked about earlier on in this presentation. We have to think biology, we have to think engineering, and we have to think chemistry. If we want our restorations to be successful, we have to tick all three of those boxes. So biologically, what am I trying to achieve? What am I trying to mimic from nature? So am I trying to just get basic translucency? It seems like that's always the buzzword when we talk about zirconia, but there's so much more than translucency when it comes to the anterior dentition. Are we talking about opalescence? Well, opalescence can be very difficult. That passing through of certain wavelengths of light and reflecting of others, giving you that orange and blue appearance at the incisal edge of our restoration. That can be difficult to achieve because we know things like Emax don't opalesce. There are certain materials like Celtra Duo which do an excellent job opalescing. So when I've got a single anterior tooth that has a really strong opal function to it, and I don't want to stack incisal edge porcelain, I actually reach for a Celtra Duo block. I think they're great for these single anterior teeth to give a really strong opal effect. Now, opalescence is a function of the ceramic's submicron particle size, which causes that selective deflection and pass-through of certain wavelengths of light. Again, it's nothing crazy. Think about looking at a sunset. When you see oranges and blues in a sunset, that's what happens when teeth opalesce. In our atmosphere, it happens because of different types of particles and dust and water. That's why sunsets look different in Oklahoma than they do maybe in Alaska. We have to understand there's different things in the air, much like different teeth opalesce differently. The other thing we have to think about is incisal edge halo. So that's one of those things that we typically see, which is separate from opalescing. That halo is that unique ability of a tooth to have a little bit of translucency around the incisal edge, and it's typically rimmed in a hypocalcification. I believe one of the doctors that's presenting here coined the term halo effect around the tooth. I think it's a great thing to talk about. But also we've got dentin show through, right? So we've got some warmth in the body of teeth. So we have to understand that as well. Okay, so now we understand and identify all these different things that we're going to look at on a shade map moving forward. Well, now we have to think of engineering. Do I have the preparation I need for a pure glass or lightly filled glass? Well, I don't know. I don't think so, and you'll see when we look at the lingual of this tooth why we had to go with something that was a little bit stronger. Where are my margins located, right? Do I have deep subgingival margins? If we look at the indications for something like Empress, a deep subgingival margin is a contraindication of the material. Well, our engineering has to support our chemistry, right? So what substrate am I trying to adhere to? Is it a vital tooth? Is it a non-vital tooth? Is it a dark stump shade? Is it sclerotic dentin? Again, thinking through all of these things. Well, this actually is a non-vital tooth, so we have to have a little bit thicker margin. We know that our quality of our dentin is going to be slightly modified due to the fact that this is non-vital. When you look at my lingual on that lower left image, it goes really far subgingival due to a previous fracture that this patient had. So overall, I'm not going to get maybe the most predictable of bonds. So I want a material that when I look at my ISO standard 6872 is maybe like a class 3 dental material, something that's a little bit stronger, has its own inherent properties to retain its resiliency and strength. So no surprise, anyone that knows me knows that I love lithium disilicate. And just for a comparison, right, let's look at our biology. So we have a primarily dentin based preparation with a small ring of enamel. So we're mainly trying to replace enamel. So let's compare enamel and lithium disilicate in a biomimetic type of way. So when we look at this crystalline structure of enamel, we also have a crystalline structure with glass infiltration and lithium disilicate, albeit it's a much different type of crystalline structure, but crystals nonetheless. When we look at the elastic modulus or flexibility of enamel compared to that of lithium disilicate's actually a little bit stiffer. Right? So maybe that's one of the reasons why Emax has been such a good long-term posterior material. It's a stiff material. It's not going to flex and give. It's going to protect that ever so critical interphase layer between our dentin and our cement. We look at coefficient of thermal expansion. We see that lithium disilicate expands slightly less than that of enamel. So again, when we drink something hot or something cold, it's going to flex less than our natural tooth actually would. Both of them have very low thermal conductivity, but one place that Emax really wins out is in its basic flexural strength. So Emax has a flexural strength of around 360 to 500, depending on what research article you read. That gives it what we call a class 3 dental material strength. It's something that has a fracture toughness value of greater than 2.5. It has a flexural strength of greater than 350 megapascals. So this material could be luted or bonded, which gives me a little bit more peace of mind bonding it on this type of anterior restoration. Okay, so we've thought about that. Okay, so now we're still trying to mimic nature. So this patient, I wasted an Emax block. Sorry, but I did. I thought this was kind of interesting. So typically, I only mill one block. I take a lot of photos. I take pride in the fact that I aim high, and very rarely do I have to mill a second block. For this patient, I milled a second block just because I wanted to do one on a model as an example and one chair side in the patient's mouth. So here, this is a block that I fired without putting any color on it whatsoever. And let's go ahead and let's turn this into a black and white image. So you can see we took a tooth that had a very low value initially compared to this surrounding dentition, and now we have a high value tooth. This is absolutely excellent, because what did I tell you about matching colors earlier? Whenever we're adding any sort of stain or glaze, we have a tendency to lower our value. So now, this is what we did in the patient's mouth. We developed our shade map. So I typically have some white tray covers in the lab, and I draw out a little shade map of how I'm going to put the shades on the teeth. So we're going to aim high on our value. So we selected a B1, even though our final value and final overall hue is going to be in the A type of range. So we had some dentin show through. So with dentin show through, sometimes we have enhanced chroma in the cervical third. And sometimes that's just due to the thinning of the enamel and a little bit of the change in color of some cementum showing through. You can see then we have this increased warmth or sunset in the body of the tooth. So you can see here what my shade map looks like, and you can see how light of sunset we actually need. I think one thing that people tend to do is overdo it on the stain and really cake it on there. I I don't do makeup. I have to imagine if I did makeup, I might be pretty decent at it. One thing I learned from my wife is a little makeup goes a long way. Same thing when you're going ahead and applying your stains and glazes to your lithium disilicate restorations. Then we're going to frame the incisal edge with a little white or ivory, and then we drag that white down towards the body, as you can see in this shade map. And anywhere you see that projection down towards the body, I'm using an endodontic file, typically a size 10, to drag that white down and give us that illusion of having these dentin projections. If we want to take this and actually have our mesial and distal corners have a little blue or opal type effect, we can add that. In this case, we added just the slightest amount of incisal 2 to give just a little bit of graying effect to enhance our halo that we saw on the adjacent teeth. So now you can see, using a very small paintbrush, applying our glaze first, and then applying those subsequent layers over top. On the right-hand side of the screen, you can see what came out of the mill. Something very rough, had some burr marks on it. Overall, a very ordinary looking restoration. By the time we get done, you can see how extraordinary this restoration can become by just looking at the 3 C's, our contours, our consistency, and our color. We're developing our shade map, our topographical map, because we've recognized some of the anatomy and some of these things that we see in the natural dentition. Now, the last thing we have to do, and we don't want to forget about chemistry, but this is a lecture kind of in and of itself, I want to give you the quick ABCs of bonding, okay? So what are the really basic things that we can talk about? Well, let's start with A, okay? So people always ask, well, what do I use with this dental material? Well, first, let's think A. We're either going to use acid or air. So acid or air abrasion. So any glassy ceramic. And a tendency that I tell people is the more glass, the more etch concentration you use, and the more time you etch it for. So if we have something like feldspathic, we're going to use a 9.8% hydrofluoric acid for 60 seconds. If we have something like lithium disilicate, we have more crystal, less glass, so it's going to be 5% for 20 seconds. So it's a general trend that holds true, just understanding that basic principle. If you don't have a glass ceramic, so you have gold, you have something like zirconia, you have something like a hybrid composite material. It's not glass, so you air abrade it. So a typical safe bet is something around 1.5 barometric pressure, or when we look at it, maybe something like 25 to 30 psi isn't generally going to destroy most of your crown and bridge materials. The next thing that we have to do once we've prepared our surface is prepare an intermediate layer. So again, with our acid-based type substances, our glassy ceramics, we're going to use a silane. Okay, here's where it gets a little bit tricky. Even our hybrid materials, when we think about the basics of a dental composite, you do need to bond to your inorganic filler, which is typically some sort of barium glass or aluminosilicate glass. So silane can be very helpful with our hybrid ceramics. Metals or metal oxides like zirconia or gold or base metals, typically we're going to use something like 10 MDP or an acidified monomer, which actually creates not a covalent bond, but an ionic bond to the surface of our material to allow for that intermediate linkage to our C or our cement. So basically, if we're going to be doing something like a very thin veneer, we're going to use something like a light cure resin cement. If we're doing a thick veneer or an all ceramic crown, typically we're going to do dual cure. Self-adhesive dual cures typically are for things that are a little bit stronger, those class 3 dental materials like polycrystallines, metal crowns, endodontic posts. And then self-cure resins, typically we're going to use around an implant abutment that are cemented extraorally, something like multi-link hybrid abutment cement. So to wrap this presentation up, we wanted to start with how this patient presented and their chief complaint of a dark, long tooth that they did not like in the anterior. And in a single 2.5 to 3 hour appointment, I wish I could tell you exactly how long it was, we end up with this result. If we take this image and we aimed high, which you saw was a very high value restoration, and we turn it black and white, it looks very much the same as our opposing dentition. So aiming high will bring us to a nice lower value once we cement it in and get done with our staining and glazing. I think any old lady at the hardware store that I worked at in high school would be very happy with this color match. And overall, True Value Hardware, if you're listening, I only have 10 years left in the military, so I'm ready to go back to work in the paint department. When you look here, you can see our shaping of the tooth utilizing forces from an orthodontic type of method to close this diastema. We shortened the incisal edge, and overall we were able to maintain tooth proportions that were harmonious with the other side. So in conclusion, hopefully you can see what I took you through with this single anterior tooth. We've discussed biology. We've discussed the engineering that has to happen when we select our preparation design based off of our biology, and ultimately what type of chemistry we're going to use to support the engineered restoration that we engineered to properly support the underlying tooth structure. We've planned. Okay, so through our plan, hopefully you realize we've recognized the problem, and we've recognized that problem as a contour, consistency, or color type of problem. We've increased our communication, right? We've recorded our findings. Once we've recorded those findings, we can then communicate that with our lab, with ourself, with our patient, to recognize all of the problems that exist that address your patient's chief complaint. I've given you some tools, right? So hopefully I've given you some basic functions that you can use in PowerPoint to determine some of your anatomical contours. I've showed you how some of the CEREC tools that are in the computer can be utilized to get you 75% of the way there. I've given you some ideas of how to use something simple like articulating paper and a lab handpiece and a color pencil to go back to being a kid and replicate some of that anatomy by using principles we've known our entire lives. So overall, I hope you have some good questions for me. I'm humbled to be talking to you today, and I'm just super excited about where we've come in dentistry since I've started, and I can't wait to see where CEREC takes us in the next 10 to 15 years of my career. And with that, I'll leave you with my reference slides in order in which they appear, and I will open up to any questions at this time.